Hello, welcome to RheumNow. It's the RheumNow Week in Review. I'm Jack Cush, Executive Editor of RheumNow.com, and this is the Week in Review. If you've been following the website this week, you know it's been a bonanza week for biosimilars with two FDA hearings taking place in Maryland, wherein the Arthritis Advisory Committee met on Tuesday and Wednesday to consider two new biosimilar applications. The first was a unanimous approval by the Arthritis Advisory Committee, 26-0, in favor of approving the Amgen adalimumab biosimilar called ABP-501. It was a day-long hearing and a lot of discussion, a lot of getting the new committee up to snuff on the particulars of biosimilar legislation, the process of getting a biosimilar approved. We've reviewed that both on this report and previous reports about biosimilars. And in the end, they were obviously swayed to approve this new adalimumab biosimilar, the first adalimumab biosimilar to be recommended for approval in the United States, the second biosimilar approved by the Arthritis Advisory Committee. The approval was based on a large body of preclinical work, a lot of work, pharmacokinetics and primary and secondary structure work and immunogenicity work showing the similarity between adalimumab and the new biosimilar ABP-501. The clinical trials which proved the clinical equivalence were done in both rheumatoid arthritis and in psoriasis with favorable outcomes, identical outcomes, no new safety signals. So that has gone forward, and we'll see what the FDA does with that. The second hearing occurred the next day, almost a similar panel, this one approving 20-0 in a unanimous way to approve the Novartis/Sandoz biosimilar for etanercept called GP2015. The unique thing about this particular hearing was that they spent a little more time on safety issues, but the clinical data that was presented were in large trials with psoriasis patients. They made the case that psoriasis was a sensitive indication to find a potential difference between the biosimilar and the originator product. And of course, they did not find that. Again, this was unanimously approved. Sandoz was the first to get a biosimilar on the market with Zarxio, the Neupogen biosimilar, back in 2016, the first approved by the FDA. And they've been very active in the biosimilar market with their generics division, this called Sandoz, and they have biosimilars approved all around the world. So at this point, we have the Arthritis Advisory Committee recommending three of the first three biosimilars for approval by the FDA. The first one, which they heard in February, was approved by the FDA almost 2 months later. So we'll wait and see what will happen with these particular two biosimilars. There were no bumps in the road. There were no new surprises. Both panels did struggle with the issue of extrapolation, meaning they did a few limited trials in RA or psoriasis, but then they're going to get all the indications of the original product, and the issue of interchangeability, which is not really being sought for by these applications. Also in the news this week is a new FDA approval of Xidra, Xidra, or lifitegrast. This is an LFA1 agonist that blocks the interaction between LFA1 and ICAM1. It turns out that ICAM1 is highly expressed in patients with dry eye syndrome, and there are 16 million people in the United States with dry eye syndrome. So they did a few 12-week studies showing that BID dosing of this eye drop was efficacious. This drug was up for FDA approval last year, but because of a discordance between improvement in signs and symptoms and improvement between signs and symptoms, they made them do a third study which affirmed its efficacy. This is a drug being approved in 1,100 patients with dry eyes. It did include some patients with secondary Sjogren's. However, Sjogren's is not a specific indication here. The trials were largely done in women with dry eye syndrome. So we'll wait to see what happens. We don't know the pricing of that drug. The safety seems to be reasonable. Some local side effects, a screwy side effect of dysgeusia or an abnormal taste in the mouth based on using the eye drops. So we'll see what that means with continued use. Also, the FDA, busy this week, issued a release talking about the appropriateness of using cryotherapy. You may be familiar with whole body cryotherapy, where the body is cooled down several hundred degrees Fahrenheit, with a short stay in usually a chamber about the size of a refrigerator box, and you're in there for 2 to 4 minutes. It's been used extensively in the past to treat post-athletic injuries, but it's been seen a lot wider use and a lot of wide claims, including its potential use in osteoarthritis, rheumatoid arthritis, fibromyalgia, Alzheimer's, asthma, migraine, and multiple sclerosis. So it's getting a little out of hand. The FDA issued a release saying, one, it's not approved. Two, there's really very little evidence for its efficacy, and so they can't certainly condone it. And that this may be not only not effective, but it certainly seems to have risks of asphyxia, frostbite, burns, and even damage to the eye. So that's available on the website for reading. And lastly, an important small study in PNAS, which looked at 17 patients with rheumatoid arthritis who were treated with vagal stimulation. They used a small cardiac implant, small device, and that was implanted and designed to deliver a stimulus to the vagus nerve up to 4 times a day. Animal models have shown that this was highly efficacious and that it basically induces an inflammatory reflex which inhibits tumor necrosis factor alpha. And they showed that this in fact happened in animals and also in humans, where the use of the stimulator reduced levels of IL-6, TNF, and IL-1. In their trial with rheumatoid arthritis patients, they showed the same reduction in cytokines, but also a reduction in DAS scores, suggesting this may be yet another way we could effectively treat rheumatoid arthritis in a novel way. A number of different items were posted in our social media feed. A review article on lupus panniculitis telling us that it's diagnosed as by finding indurated nodules or plaques, often with lipoatrophy, usually found on the proximal extremities and or trunk. If it's found on the breast, we call that lupus mastitis. You can find this in up to 15% in some series, but probably lower than that based on my own experience. The key here is getting a deep biopsy. You won't get a diagnosis of panniculitis with a simple punch biopsy. Usual treatment is hydroxychloroquine, steroids, sometimes dapsone, and there are a bunch of experimental therapies as well. There may be a discordance between the appearance of lupus panniculitis and lupus activity. A review of a cohort of 428 patients with both axial and peripheral spondyloarthritis examined the influence of obesity with a high BMI on the scores that we are now using to assess AS and SPA patients. And that is the ASDAS, the Ankylosing Spondylitis Disease Activity Index. And Desiree Vanderhyde and other people show that even though the ASDAS does include PROs and the CRP, the BMI itself weakly correlates with both the CRP and other PROs, patient-reported outcomes. Now, the only correlation was found between BMI and the CRP in women. Their cohort actually was a majority of women, and they did not find a significant effect on the ASDAS. An FDA advisory committee, as you know, has voted 26-0 to approve the adalimumab biosimilar and 20-0 to approve the Sandoz etanercept biosimilar. I already covered that. A small study, I looked up and found a small study about what happens when you use or don't use Bactrim in patients who are being treated with Bactrim for GPA or Wegener's, and it showed that relapse rates were actually much higher, 45% when you were not when Bactrim was discontinued in patients with Wegener's, but if it was continued, the relapse rate was only 25%. A 20% difference, suggesting continued therapy, even though patients are stable, might be appropriate. The German rabbit registry was analyzed to look at GI perforations, especially lower GI perforations. They did this by looking at over 13,000 patients with rheumatoid arthritis, and they did find an increased risk of GI perforations with Actemra, 2.7 events per 1,000 patient years. A very low incidence, but that incidence happens to be 4 times higher than that seen in patients on other therapy. The unique thing here is that the occurrence of lower intestinal perforations in those patients with Actemra, 25% of them actually died. So we need to be vigilant in looking for that. A number of reports came out looking at the prevalence of gout in the EU. It's risen from 1.7 to 2.5%. In the US, the prevalence of gout is as high as 5%. These reports suggesting gout is becoming more prevalent in society where obesity and diet are a growing issue. Looking at the issue of the impact of vaccinations, a German study looked at over 100,000 patients with rheumatoid arthritis throughout Germany and compared that to over 500,000 normal controls. What they found was that actually rheumatoid arthritis patients are vaccinated more frequently. Unfortunately, though, it's still not a high enough number for both the general population or rheumatoids. They also did find that more cases of hospitalizable pneumonia were seen when patients were not vaccinated or were from regions where there were low vaccination rates, suggesting there really is an impact to vaccinating our patients with rheumatoid arthritis. And lastly, a review of the durability of Rituxan. 234 RA patients treated with Rituxan for up to 28 months found that the discontinuation rate, the retention rate was 57%, and that discontinuations were associated with higher age, more swollen joints, and not using background methotrexate therapy. So that's it for the RheumNow Weekend Review. If you want to see these citations and find out more information, go to the website, look at the video, or look at the feature article and find the links. You can click on those and find more information. Be sure to follow us on RheumNow for more exciting news and information about research and developments in our field. Do me a favor and yourself a favor by going to the website and registering. Registration comes with a bunch of benefits, being able to download slides, being able to engage in discussions, being able to participate in surveys, etc. So that's it. Tune in. We'll see you next week.